women across their lifespan, what are their health issues? So, they try to promote it. So, you are also going to celebrate it with the different departmental speakers. So, your batch will be the fan name. Your batch will be the most beneficiary out of that. There will be one national program, so community medicine will also be involved. So, I will tell them also in the next class. So, I want to see maximum participation from your class. Okay, your attendance will be marked over there. Next Wednesday, I will come out with a notice, probably next Wednesday, 1:30 p.m. or 2 p.m. So, now I continue with neurocognitive disorder is over. So, next group is the substance use related disorders group. So, as per International Classification of Diseases, 10th I am arranging it. Okay. So, that was 0 to 10, now it is 10 to this 20. Okay. So, substance have you come across substance use disorders questions in your previous year question, UIQ? Are you asked on them? Are you asked on them? Haven't you haven't noticed? So, I won't go in much detail of it, but few things are very common, at least alcohol intoxication, alcohol withdrawal, those patients often come, even in medical emergencies they land up. Holi is a period to come across. So, all the people who are attending ER they remain in anxious that okay, we will come across these things today. Holi, Vishwakarma Puja, and also during Vijayad, so some cannabis intoxication. So, and these substance related areas, there is one legal issues also been involved, that there is some of these substances are considered as illicit, where their consumption is considered to be a crime, or some of them, if you possess them in large quantity, they are considered to be crime. Forensic part is over, that is called NDPS Act. I don't think you would be asked much on NDPS. So, let us then, what is this substance use disorder? Commonly we call it, this is previous, the term came with the most commonly, the term that we use in our day-to-day discussion, we call it addiction. Other than illicit, like when you talk about alcohol, when you talk about tobacco, then there is that socially permissible intake is there. So, the concept of addiction is where the issue of mental health is coming. So, somehow with the passage of time, maybe to destigmatize a little bit from the layman's word to the medical word, this Initially came substance abuse, substance dependence. Now the 11th ICD, 11th International Classification of Disease and DSM, they call it substance use disorders. That after a benchmark it become a disorder. Before the benchmark it doesn't become a disorder. Alcohol anybody can take on. Where it is the boundary of being in a socially permissible or permissible in terms of health, and where it is becoming disorder. Now they have conceptualized this disorder. Hey, attendance gulo ne. On a cross-sectional intake basis, like suddenly somebody has gulped lot of substances, so that will result to some health hazards. So that is an intoxication. Substance is a chemical. So chemical intoxication. Then somebody is taking over a long period of time, then it is over a long period of time it is causing health hazards. So that is harmful use of the substance. That may be medically, socially. Somebody is sober, not disturbing the family or work, but hampering his or her personal health. That is also a harmful use. Somebody might say, okay, look, I am healthy, but every night that person does wife battering after intake of alcohol. That is also a harmful use. Somebody comes for work, very good, efficient worker, but afternoon he goes for a drink. That causes disturbances in the workplace. That is also a harmful use. And then there is somebody, this till now when there is the choice remains, then we call it more of harmful use, where the person is okay. They know that okay, it may be harmful, but still they are taking or something, or they say okay, this is not something of denial they are in. But when it's not in their hand, they cannot control it, then we call it dependence. They are not taking it by their choice, they are taking it by compulsion. We call it a dependence. So, why out of so many chemicals, few people consume? Definitely consume for some pleasurability. Why some people consume some particular chemicals? Substance is a general English word. Not all the substances or all the matters or all the chemicals come under substance use disorder. So, now substance are usually those chemicals which have themselves some chemical representation in our brain to produce little bit of pleasurability, drive. Why persons take substance? To enjoy. So what is enjoyment? A sense of well-being, feeling good, doing certain drive. So, the substances are the chemicals who have already they have a natural representation, or they trigger certain cerebral pathways which are important in this emotional and drive related activity. In our brain, there is an area called reward center. Have you heard of reward center? Reward center. And that reward, that accomplishment of reward comes from the phasic release of dopamine. Dopamine is a neurotransmitter. It has 5 different pathways. You have studied in, I was talking about Parkinson's and you were talking about nigrostriatal path. Who was talking about he was talking about nigrostriatal path. So that is one pathway, dopamine. Another, you must, whether you have heard or not, or whether in gynecology whether you have heard or not, that from the posterior pituitary that prolactin comes. Now in the posterior pituitary and under influence of hypothalamus, that releasing hormones. So that is an infundibular hypothalamic pathway where dopamine acts as a inhibitor of excess prolactin. So dopamine also maintains the balance of the prolactin cycle, and then this prolactin to other women gynecological cycle. So if dopamine is reduced, the prolactin goes high. And what are the side effects of prolactin goes high? I am not going into detail. Those are there. So this is one cycle. Another is the drive, our pleasure. This is from our emotion and our activities and decision making. This is a frontal lobe and our this temporal lobe limbic system, this pathway, this is a reward center. Now one of the importance of reward is that we don't get reward every day. You get reward on certain period of time, certain time of the year or something like this. And nobody knows that who is going to be rewarded. Everybody participates in the competition with an equal hope of getting the reward. And that's where the pleasure of reward is. That it is to some extent unpredictable. And it will come suddenly. You always don't know when your mood will be elevated, when your mood will be little down. But this transition always happens. And when you will be energetic, when you don't become energetic. Situationally it becomes, but naturally it also. So that is that depends on this phasic rise of dopamine. So dopamine surge to some extent similar to the menstrual cycle of women, which is very not unpredictable, it's very predictable. The surge occurs and then withdrawal occurs, then the menstruation occurs. So this is another, this reward center. So some of the people, this phasic release of the dopamine gets disturbed by a tonic release of dopamine. What is tonic? That is a constant, same pattern. It's not a peak and drop doesn't happen. So they don't get that pleasure. And unless you, in substance also we call it a kick, we call it a hike. So what is kick? Suddenly you make a shot. Somebody is running with the ball. suddenly make a shot. That's a kick. Somebody jumps. It's a hike. So that natural kick and hike becomes absent in them. So they need this external chemical from time to time to give them this kick or hike. Now their brain becomes so attuned that when this becomes like when they are not taking it like a natural pattern, this becomes a pattern for them. They need evening I need to take, or after certain time I need to take, and when they don't take it, they feel so low. So that's what they describe it as craving, the urge to take the pleasurable substance. And one interesting thing is, okay, you can have a urge to take certain, to go for a movie, to have a food. So telling everything, any urge, any search for a pleasurable activity, craving, we need something more determinant. The most important determinant is that the person loses control over its initiation and stoppage. Okay, somebody wants to go and, okay, let's go for party. Go and take certain volume of alcohol. I am going, but what is the volume that is permissible? I am going later. But when I am talking about conceptually what is this addiction is, that the person doesn't have the control. So when the time will come, that might interfere into his social, personal, occupational life. That person who is going at 2 p.m. from his office, that particular point he is having the craving to initiate, he doesn't have a control. And if he goes for drink, he won't be able to come within 60 ml or 80 ml. So that's what this craving is concerned. The next thing is, there is a called tolerance. In pharmacology, tolerance word been told that receptor sensitivity gradually reduced with the amount of substance being on the circulation, that Cmax value and the circulation. So they don't get the kick, so need more. So towards this addiction or dependence, the second criteria is tolerance. If the person had the pleasure at 2 peg 6 months back or 1 year back, is not getting the same pleasure. So tolerance. And with this craving and tolerance, what happens? There is because this is not in the control of that particular person, so there becomes a kind of a restriction of the personal social repertoire. Everything focuses on alcohol. Whether at 2 p.m. there is a meeting, I must go and take the alcohol and then come. There is a marriage party at 8 p.m. I need to go and come. So restriction of repertoire of life. And finally, it becomes, with all these things, if the person doesn't take the substance in this pattern, experiences different physiological reactions within the body, which is called withdrawal. So please note down these 4 things: craving, tolerance, then withdrawal, then restriction of repertoire, now restriction of repertoire, yes, restriction of repertoire, repertoire means what are the activities the individual is doing. you can say these activities, social personal activities, schedules, okay, that gets very restricted. And this is an extension of point, that is that despite knowing the thing is harmful, the person cannot stop it. It is part of the almost this withdrawal and tolerance and something that he cannot stop. He comes and say, I cannot. So this is what called the substance use disorder dependence. Now, what are the substances on which the person can become dependent? The most common that which are medically harmful is tobacco. But it is so much socially acceptable, so we hardly discuss it in any addiction platform. And it does not have much of socially, it does not lead to much socially inappropriate behavior or disturbance of the social repertoire. So it does not lead to, since it does not lead to so much of behavioral disturbance, though it is the most harmful determinant of all systemic disorders, from neurology to cardiology to respiratory medicine to even GI in terms of malignancies or in other parts and malignancies. Everywhere the topmost cause comes tobacco. Since the behavioral part is not that disturbed, so this is not been discussed much in the mental health perspective. So in the mental health perspective, that becomes in the prototype is alcohol. Alcohol use disorder, where you have an intoxication, where you have this Phasic harmful use to a dependence or an withdrawal, then withdrawal, only the physiological withdrawal and the medically complicated withdrawal where the individual needs to get admitted. So alcohol is a thing which is a, so alcohol is a natural chemical, OH. So we have similar representation in our body, so many things, and in brain it is related to two more things. One is opioid, another thing is this final pathway of dopamine. So if alcohol works via opioid, then opioid itself is also an addictive substance, and opioid is a stronger addictive substance. Once you go the higher step, so opioid dependence is more chemically disfiguring. Like if somebody takes alcohol to become a dependent, like we can socially acceptable alcohol user, we can say, but hardly we can say there is a socially acceptable opioid use disorder. It very quickly transforms into a mental health problem. It disturbs the cerebral circuitry very quickly. If it goes a step higher, dopamine, then that becomes even higher or even more illicit. Cocaine or the MDMA or these party drugs, these are coming. Even a single shot that changes the cerebral circuitry. So this is the way physiologically this substance use pattern progresses. Now, so we will discuss mostly related to alcohol. we are talking about the harmful use pattern. So, WHO has come up with a definition of substance use, that because we are talking about that socially permissible. So, in many parts of the world, it is a natural daily beverages. So, there is a social influence in the pattern of use of alcohol. So, one of the professors of this addiction psychology names used a fantastic word. I still quote him. Then in Western, they do ahar with alcohol, and in Eastern population, they do bihar with alcohol. So, in ahar, they take the pleasure of the taste and the flavor. So, they take all socially, everyday dinner, grandfather to the grandchild, they are all sharing small drinks in the small glasses. And what is the limit is 100 ml. Till 100 ml. If somebody is taking per day at one or multiple divided, WHO has decided to put a score 0 to make it in the AU scoring. So, beyond 100 ml per day consumption is considered to be an alcohol use disorder pointer. So, no more this is a socially or medically permissible. Though that concept has gone, that something again chronic use, there was previously used to be said that okay, it increases HDL, it good health. This is not, because regular consumption that causes a different metabolic pathway. That will have to be corrected from your metabolic levels of lipid metabolism and your liver function test. So, it is not a one-to-one. At one point of time, there was a perception was created, okay, you take every day and you remain healthy. That is not. But so far as behavioral perspective is concerned, mental health perspective is concerned, WHO has decided 100 ml. Now, this is the intoxications. So, what happens in intoxications? According to the serum level of alcohol, it goes, it varies. More and more it goes higher, it might lead to even death or respiratory depression. So, initially what will happen? Little bit of that a dizzy, or your clarity of thinking will little go down. All kind of that, whether somebody takes it to be pleasurable or unpleasurable, those things come. Little bit of euphoria, this emotional and cognitive part. Cognitive clarity goes down and emotional euphoria and disinhibition gradually it progresses. So, till 80 is like this. Then it goes beyond 100, then the disinhibition starts. They start talking much. They become more. So, what is how alcohol works? Alcohol works via GABA. So, GABA is a cortical depressant. So, it depresses the and cortex work by depressing the subcortical glutamate, and that glutamate is all the disinhibition, motor, this behavioral disinhibition, motor disinhibition. So, somebody becoming hyperactive, somebody talking more, somebody becoming hyperactive. This is from beyond 80, these changes. Then close beyond 150, 200, this might vary. That is where the tolerance is. If for a beginner it will be at much lower, but For a chronic user, it will vary. So once it goes beyond 150, 200, then the motor incoordination starts. Larkharate hai. In speech and walking, cerebellar pathway gets disturbed. Beyond 200, 300, gradually, even from this coming down, from frontal lobe to it is coming down the track. Then to the hindbrain, the vital centers. Autonomic surge, there may be so much of tachycardia might go into arrhythmia, there may be circulatory collapse, there may be respiratory depression, beyond 400 there may be respiratory depression. So this is the way how this intoxication progresses. So what is the management of intoxication? Mostly supportive. Any supportive measures starts with ABC. Have you heard of ABC of supportive or critical care? Anybody? A? ARA. So ARA or respiratory depression is happening. Okay. Next is B, breathing. You check the airway, then you see the breathing is happening or not. Then you see the circulation in pulse and BP and everything. And then there is, if the person is conscious or not, then you go for the blood level or others. So management is supportive. If the person has so much of vomiting, it affects your GI. The vomiting you give, the vomiting, what is the most important electrolyte might get disturbed in vomiting? Huh? Sodium, very good. And in diarrhea? Potassium. So what is the fluid which is of importance in sodium? What is the fluid where we replace this sodium? Huh? What is somebody's cognition is already disturbed, confused. So fluid they need to be an IV channel that the circulation is disturbing. Normal saline. Isotonic normal saline. Isotonic normal saline. That the circulatory maintenance. For any patient who comes to emergency with vomiting or circulatory collapse, you give normal saline. There is another fluid called DNase. So can we give DNase in place of normal saline? You haven't discussed in this way earlier in fluid management? Any class on fluid management? No. Okay. What happens? Here the osmolality is maintained by 50% by sugar, dextrose, and 50% by sodium. If the sugar gets metabolized, sodium doesn't get metabolized. Sodium remains in the fluid for osmolality. When the sugar gets metabolized, the osmolality falls. So never give DNase in a circulatory collapse. Sister says, sir, DNase ta nahi, DNase ache, diye dobo. No. You look for. You might give you start with the DNase immediately because you need to give fluid. But immediately ask for. Then you can give colloid if there is circulatory collapse. Blood loss, blood is a colloid. Here there is no blood loss. Certain fluids come as colloid, better crystalloid, but DNase not. Another very important issue of DNase or dextrose, somebody is not eating. Here we give dextrose where somebody is not eating, we need to nutritional support. Somebody is drinking pattern is called binge. Throughout the day somebody is drinking. Nutrition is highly decompensated. Then whether the person should be given, it's another question that Dextrose either in the form of 5D or why 5D? Because 5D, when it becomes 5%, then it becomes the osmolality. The osmolality is to be managed. Molar equations. Now, in the sugar metabolism, there are two pathways in biochemistry. One in the cytoplasm, another in the mitochondria. Who will tell? Cytoplasm. Glycolysis. I asked from this. And what is the mitochondria? Huh? Krebs cycle. I asked from this. So, one of the very important cofactor for this glycolytic pathway is thiamine. So, when glucose enters into the system, the thiamine, circulatory thiamine enters into the metabolism, it gets consumed. Now, in chronic alcoholics, one of the metabolic changes and metabolic end result is thiamine deficiency and niacin deficiency. So, this thiamine deficiency, it gets into a sudden crisis because that glucose metabolism, there was no glucose intake for certain hours. Suddenly glucose into circulation, so the body is hypermetabolic. They suddenly try to get into oxidation of that glucose to get the energy. Body is starved. So all the thiamines get consumed, and that leads to certain neurological complication. Do you know that certain neurological complication of sudden thiamine use up from the brain? Wernicke's encephalopathy. Okay. That is a demyelination of this motor tract from the long tract that is coming frontal to downwards. That is Wernicke's encephalopathy. That both encephalon, even the grey matter, so consciousness will go, even the long tracts motor, cerebellar, those things will also come, even down to the brainstem, that gauge paralysis. There is a triad for Wernicke's encephalopathy. Ataxia, nystagmus, confusion. You think it in this way: consciousness, cerebrum. Then the long tract, this is the motor of our limbs, balance. Then nystagmus, it is the lower brainstem, those tracts. Okay, Dolce, have you heard of Dolce? Dolce phenomenon, Harrison, or even in Davidson, I think, Dolce. What is Dolce? Wherever you turn your head, the eyes goes. That's what, no? You turn the head of the doll looks this way. The eyes get deviated. When you turn your head, the eyes remain in the center. I cannot see like this. I cannot do a saccade like this. I can do, that is a saccade, but on turning my head, my eyes does not go. My eyes remain in center, my head turns and then I see. But in doll's eye, head moves, eyes also move. So, that is what it is supposed to be if it is a brainstem phenomenon. It has been prevented by our cortex. No, you don't need to do it. You don't need to deviate your eyes. So, when there is an encephalopathy or coma, Dolce phenomena sets in. The cortical control gone. Coma is the lowermost of consciousness that comes from the consciousness disturbance is your cortex. The difference between meningitis and encephalitis, when the consciousness goes, it is encephalitis. When the person is hyper alert and with the motor symptoms and sensory symptoms, with the fever and other things, then it is meningitis. When it progresses into disturbance of the consciousness, it is encephalitis. So, this coma, Dolce phenomena, the cortical control over this brainstem movement of the eyeball goes. This eyeball movement to it, cerebellum, this and this eye centers, we call it smooth pursuit, we call it sacchards. আর তো 5 মিনিট হোল্ড কর আরে পরীক্ষার সময় পেয়ে গেলে কি করবি 1 ঘন্টার আগে যেতে দেবে না বস বস এখানটায় বস সবচেয়ে তাড়াতাড়ি বেরোতে পারবে তুই প্র্যাকটিস ইট ইয়ার হবে না তাহলে খুব অসুবিধা হলে বেরিয়ে যাস বাবা খুব অসুবিধা হচ্ছে তাহলে যা So, this is intoxication. Now, this dependence, I have defined the dependence points and the harmful use. What will be the harmful use? Your metabolism will get disturbed. Lipids will go high. That will clog your arterial system, that will change your microvasculature, so all the organs might get disturbed, degeneration of the brain, then liver it gets metabolized, so liver progresses, fatty liver to those this architecture disturbance to cirrhosis. One important thing is alcoholic cirrhosis is reversible than non-alcoholic cirrhosis. So that's what the importance of mental health management. If the person can be maintained out of this craving, the health can be preserved. And another important issue is withdrawal. So what happens in withdrawal? There was, when somebody gives certain chemicals in the brain, that chemicals get suppressed. So, natural release of GABA becomes suppressed. If somebody takes so much of sedative dependence, which are also GABA, they fail to sleep. Why? The natural GABA goes away. We sleep with our GABA. So, when natural GABA goes away and the alcohol supplementation goes away, the lower down glutamate goes very high. In the symptoms will start similarly. First, this is those craving part will start withdrawal initially, then the autonomic symptoms will come. Autonomic lower down to hypothalamus, it is in the base. Hypothalamus is a forebrain structure which is deep seated. And from there, these autonomic symptoms, then the jitteriness, anxiety, tremulousness, alcoholic handshake, then blood pressure and pulse changes. Then gradually, it will go to the cortex, they will start confusion, and even higher, it might cause this glutamate, might cause so much of excitation that it may cause convulsion. That seizure with jerks. What is that called? Anybody? Anybody? Ram fit. It's common term. Alcohol withdrawal seizure. Seizure might occur in intoxication also, but most commonly in withdrawal. Even a person takes a huge gulp, it might appear that it is in the intoxication it is happening, but it doesn't, if somebody takes huge alcohol, the metabolism also goes suddenly very rapid, the sudden drop and convulsion after 2-3 hours. So, Family might say, no sir, he had taken alcohol only 3-4 hours back. He has never been in abstinence from alcohol. Still he is having seizure. So in the metabolic pathway. So this is called complicated withdrawal and we call it delirium tremens. So confusion is delirium, I have already taught you. Now tremens is tremor, but the defining thing is convulsion. Another gynecological condition where convulsion is the deciding factor to decide from certain stage to certain stage. Preeclampsia. Preeclampsia is to preeclampsia to eclampsia. So where will be the convulsion? Now where will the convulsion will come? When the convulsion comes, it's in which group? What will be, if convulsion comes, what will be the diagnosis? Like you stage preeclampsia, eclampsia, gynecology you haven't studied. What? বল না সহজ তো কোনটা বেশি সিভিয়ার eclampsia তাহলে কোনটা convulsion eclampsia use your logic no use your common sense it starts with gestational hypertension then proteinuria this is preeclampsia then it is convulsion that is eclampsia similarly here tremens first is tremens motor then delirium, confusion, then convulsion, the entire syndromic complex delirium tremens. Try to understand by concept, it will be easy to represent. I don't come with PowerPoint to one of the main reasons that PowerPoint becomes boring, people are looking over there, one-to-one interaction goes down. Another thing is, PowerPoint is a structured thing, I am not thinking. I have made the slide and I am reading it out. But here I am thinking and making you think in what way it progresses. And from one topic to another topic, this jump, that is very important for your understanding of physiology and disturbance of physiology, the pathophysiology. So this is withdrawal and delirium tremens. So we have covered alcohol. So what we need to do? We need to do that ABC. A thiamine supplementation is very important. Loading dose of thiamine supplementation, even up to 600 milligram per day at that point of time. Maybe along with it pyridoxine might also be given. Another niacin, niacin deficiency 3D. Louder. Yeah. So first is, don't say dementia first. So diarrhea. Diarrhea, dermatitis, Cushal's necklace, then dementia. So in an alcoholic patient, what are the, if somebody asks what will be the any skin stigmata, you might get a Cushal's necklace. Photosensitive area. Why necklace? Photosensitive area. Why here? Here the light falls. So niacin deficiency. Then this acute neurological decompensation, both thiamine and pyridoxine. You need to give high dose of pyridoxine, you need to give high dose of thiamine along with these fluid supports.